So I'm going to talk a little bit about twitching and then a bit about Botox, a little bit about cosmetic stuff as well, just because something that I do a little bit of and it's interesting, and I thought some of you might be quite interested to know what you could do. And I guess it came about because I've seen quite a few children in particular, but also younger adults with lots of twitching and flickering and blinking, and they're really annoyed by it. Lots of referrals for, do we need to be worried about it? So I sort of wanted to look into it a little bit for myself as well and go, hey, when do we need to worry about any of this? What can we do? How can we get these patients a bit happier? And which ones do we really need to look and see? So we'll start with sort of this childhood excessive blinking. So these are the kids that come in and they're doing this, and it can be an habitual thing where they're doing it all the time, or it can be an intermittent, sporadic thing. It's really, really, really common, actually. Normally in children under the age of 6, it does become a bit habitual. So when they're doing it all the time, they keep on doing it. But it's essentially not pathological. So you don't really have to investigate any of these children as long as they're under 6 and it hasn't lasted longer than 6 months. And as long as it's simple movements. So what that means is it's always the same sort of thing and it's always just one movement. So if it's always a blinking and that's what they're doing, it's fine. But if it's a blinking some of the time and then some of the time it's a motor tick or a click, and some of the time it's something else, that's when you should start to be a little bit more concerned. So if it's a complex kind of movement, then we're more worried about it. I know that some of this will be absolutely barn door, but of course we have to exclude anything that could be causing them to blink and screw their eyes up. So that whole one eye closed all the time, and have we got a strabismus or an exotropia? Have they got some kind of refractive error, or is it actually some kind of corneal pathology, a foreign body, blepharitis, dry eye, all those simple things? They're all going to exacerbate this blepharospasm in these children. But if you exclude all of that, it's a simple movement and it's lasted less than 6 months, just tell the parents, nothing to worry about. It's really common. You've got to try and avoid talking about it. You don't want to make a big deal about it, and it will just all settle down and go away. Easier said than done, but actually does prove to be true. But what about the ones that actually do have a problem? So childhood tic disorders. These are usually or often hereditary, so there's usually some kind of family history of the problem. They could be motor tics, shrugging, blinking, or vocal tics, which come in all sorts of ranges. Common in children and adolescents. If they're less than a year in duration, they usually still resolve spontaneously, but once they get beyond that, we're starting to get into the territory of something that we might need to offer some treatment for. And they're often described as involuntary rather than involuntary, so that's not my bad grammar. Involuntary being something that you really have no control over, involuntary being something that you don't want to do and that you can learn some behaviours to suppress. So there's no special treatment for them. This is all about learning to kind of trick your brain or trick your body to stop performing the tic and stop doing it. So really they have to start to learn something that can stop them from ticking. So they can usually have some kind of feeling that this tic's going to come on. So you might just do a simple breathing exercise and say, when you get that sensation that you're going to want to squeeze your eyes closed, just take a deep breath. And it all sounds kind of crazy, but it works. So it's just simple things like that. But of course we do have Tourette syndrome, which is the most common childhood tic disorder. And this is usually diagnosed, or can only be diagnosed after children have had more than 12 months of some of these complex tics. They need to have a complex tic to be diagnosed as Tourette's, so more than just a simple blink or shrug. It has to comprise multiple, either lots of different motor ones or a verbal one as well. It's commonly associated with other conditions, so ADHD and autism commonly goes along with having these complex tics. Again, habit reversal is really the kind of treatment mainstay for these, teaching people to recognise a feeling and then using a competing response to control it. So almost always, but not every time, these tic disorders are nothing to worry about when these children are coming in. If you've excluded the visual pathology, you just have to reassure people and tell them there's nothing they can do, teach them about distraction, other techniques, but tell them that their children do not have a brain tumour, they do not need to be investigated, and mainly they don't need to worry about it, it will go away. So what about adults? Is it the same thing in adults? So I see a range of people coming in with twitchy eyes in adults. The most common is a minor intermittent twitching, and it's usually the lower lid. Often it's a feeling that they can feel their eye twitching a lot more than they can actually see it. So when you ask them, do you see this in the mirror? They'll say they can sit there and stare, but they don't actually notice the flicking, but the sensation's really, really troublesome to them. This is usually exacerbated by sleep deprivation and stress. Again, we've got to get rid of all those normal things that can cause blepharospasm, as in dry eye, dysfunctional tear films, allergens, trichiasis, all of that kind of thing. These people definitely need reassurance that there's nothing going on, that there's nothing wrong with them. They don't need to investigate and they don't need any treatment. I have, however, seen quite a number of them where it's just gone on and it really is driving them quite batty. And for most of these patients, you can give them one dose of Botox to sort of break the cycle of that twitching and spasming. It actually settles it down and it goes away and it doesn't tend to come back because it's not driven by a central neurological problem. It's something else that's just got sort of slightly short-circuited and causing a little bit of an annoying twitch. So what do you reckon? Reassure them, tell them there's nothing wrong, send them away? Any takers on what's going on with this man? Or what you can see? So he's got a bilateral upper lid frequent blink, basically. He's blinking and blinking and blinking all the time. And then this bit, he stops. And if the sound was playing on the video, and it's deliberately not, this would be me sitting here telling him, can you try and keep your eyes open? And so these patients, they come in and they sit there and they talk to you and they look at you and they're completely normal and they keep their eyes open, there's nothing wrong, and then suddenly they have these sort of episodic periods of blinking and twitching. And this is benign essential blepharospasm, and it usually starts as a very, very intermittent occasional problem and then slowly gets worse and worse and worse. The interesting thing with it is that they can control it. So they can stop it. So if you ask the patient to concentrate and keep their eyes open, they'll sit there and they'll hold their eyes open and it won't happen. And so for a long, long time, this got called a fictitious disorder or a functional disorder, and people got told that they were just making it up and that this wasn't actually something that was pathological disease, but it is. And they're really, really troubled by it. And if it's not treated, it gets worse and worse and worse. And it gets to the point that people can't work, they can't drive, they can't live their lives, they can't watch television, they can't do anything. So the features of it are that it's a localized facial dystonia, so it only affects the eyelids. If you start seeing twitching and flickering and things that are happening in other parts of the face, it's not benign essential blepharospasm. It's an involuntary contraction of the orbicularis muscle, so it's basically all to do with squeezing and closing their eyes. There is a small subset of people who have an apraxia. So an apraxia is when something won't work, so they actually have trouble opening their eyes. So rather than flickering and blinking, they actually sit there with their eyes closed and they just actually can't open them. And then they'll be able to open them again, and it's like those signals have reconnected, and then they'll go about their day a little bit more, and then they'll have another period of time. But you can imagine that if you're driving your car and you get a period of apraxia, that is probably not ideal. And so I've seen patients who come in and they tell me that they're driving along and that all they can do to be able to drive safely is sit there and hold their eye open. So it really is quite a significant problem for the majority of them. While it occasionally does start unilaterally, it's never unilateral by the time they get to the point of presenting and coming in and complaining about it. So if you see someone who's got a lower lid twitch and it's flickering and occasionally annoying them in one eye, while it's possible that that will go on to be blepharospasm, it almost never is. It's the patients that come in who've got this bilateral problem that you need to be thinking about. And why do they often present to you, and why do I think it's really important that you think about it? It's usually associated with very significant glare and photosensitivity. And so lots and lots of these patients will come in and they'll say, oh, my eyes are so sore and I can't keep them open and I'm sensitive to light. And you start to think that this is a secondary blepharospasm, that the reason that they're doing this all the time is because of their glare and their dry eye. But in actual fact, these are synonymous with each other, and unless you fix the blinking, you won't fix the glare and the discomfort. So while you still have to treat that and give them lubricants, unless you treat the blepharospasm, you won't fix them. And it really does become life-altering and debilitating. So who gets it? It's another one of these wonderful diseases that affects more women than men, 3 times more women than men. While it's most common presenting between 40 and 60 years of age, I've certainly seen a lot more younger people presenting now. So I've got quite a collection of young men, particularly with benign essential blepharospasm. So I don't know whether that's a stress-related thing or whether we're going to turn out to find some other kind of pathology behind it, but can certainly happen at any age. It's reasonably common, so 2,000 cases, new cases every year in the US, 30 per 100,000 people. So it's something that you're going to come across and see. As far as the pathology behind it, less than 1% of people have some kind of identifiable pathology. So you don't need to image these people. We never find something going on in their brain that's the cause of this. You know, less than 1% it can be connected to a stroke or demyelination or some kind of lesion. What about the risk factors for it? Mostly it's idiopathic. The theory is that it's due to abnormal function of the basal ganglia. So the basal ganglia is the part of your brain that's implicated in Parkinson's disease. And sort of the thought is that in Parkinson's disease, something happens in the basal ganglia and everything starts to slow down and not quite work according to the way that it was designed, which is why people have trouble initiating movement and why their facial expressions will change. The theory is that with benign essential blepharospasm, those signals are a bit activated and there's more going on than there should be, and that's what causes the increase in the blinking and the dystonia. There is a risk factor if you've got someone in your family history, if you've got a family history of dystonia, but there's not a clear genetic pathway for it. So if you've got a patient with blepharospasm, it doesn't mean that their children are necessarily going to get it. It does seem to be more common in patients who have a history of severe dry eye, intraocular inflammation, some kind of meningeal inflammation or something like meningitis, and light sensitivity. But some of this is very difficult to tease out because patients who have blepharospasm have all of these things. So what came first? There's no doubt that stress is a factor in at least exacerbating this. It's probably not going to be the main thing that actually causes it to happen in the first place, and I think all of us have stressful lives one way or another, but certainly being able to modify those things that increase your stress can help you to be able to control your blepharospasm. And there are definitely lots of medications, anti-nausea medications, common things like Maxilon and antipsychotics that can bring this on. And I wanted to get a photo of her, but she didn't turn up for her appointment. But I've got a very, very amazing lady who I see regularly in my blepharospasm clinic at the public hospital. She's now in her 60s, and David's looked after her, but he's not here. When I first took over the blepharospasm clinic from Ken Tarr, I've got lots of great stories about taking over the blepharospasm clinic from Ken, but one of the things I inherited was this lady. And when I first met her, she was in her late 50s. She came in a wheelchair. Every time she came into clinic, she asked me to put in an application for her for a motorised wheelchair because she was completely stuck. She'd been put in a rest home, even though she was in her 50s, by her family because they couldn't look after her anymore. She had one arm that worked and one arm that didn't work, a facial droop. She was really poorly, she wasn't really able to talk or communicate, and she had this terrible blepharospasm and couldn't open her eyes, and really dystonia all through her body. And we just gave her regular Botox to try and keep her eyes open. And about 5 years after I'd been giving her this treatment, she walked into my clinic one day. And within the 3 months from when I'd seen her to when she came back, she'd got a new GP. And her GP had stopped 3 of her medications. And those medications were what had caused all this dystonic reaction that had basically subjected her to a life of not being able to work, being committed to a rest home, losing all her relationships with her family. And then she got this new GP, and now she has a job, and she still has blepharospasm, so I still get to see her and see this transformation. But she has a job, she's living independently in her own flat, she's been reconnected with her daughter, and she feels like now that she's in her late 60s, she can live again. So it's a really cool story when you see the other side of it, but also a pretty sad indictment on what we can do to patients with all these medications that we can give them. So, well, they were antipsychotic medications. So she'd had an episode of depression, I suspect, that started it all. And then I think what probably happened is that she had depression. They gave her an antidepressant. The antidepressant caused some dystonias. They associated the dystonias were the sort of progressive neurological condition, and then they just continued to treat her with more medications to treat her dystonic reactions. And she was on Valium and clonazepam, and so yeah, that's right. And it was a slow withdrawal, but and one of them was probably more significant than the others. But yeah, it's just amazing. So fortunately, I no longer get requests to fill in the application for the motorised wheelchair. Cigarette smoking is interesting. There were some early studies that showed that there was an increased risk of developing blepharospasm and other dystonias and neurological conditions in cigarette smokers. Actually, in later studies, that hasn't been proven to be the case, but I still tell them all that it'd be really good for their blepharospasm if they stop smoking, if they do. So what happens with it? It does definitely progress, but usually over just a few years, and then it becomes stable. Unfortunately, it basically never goes into remission. So once you meet these patients, you've got them for life. Of course, it can occur secondary to other eye pathology. So you can get blepharospasm in response to a severe dry eye or some other kind of ocular inflammation. So you will see patients when you treat that their blepharospasm goes away. But that's because they've got secondary blepharospasm, not benign essential blepharospasm. I think it's just really, really important to think about this in this cohort of dry eye patients. You do also see it in other systemic movement disorders. So in Parkinson's disease, you can see a bit of this dystonic sort of flickering. And again, it's probably because of this connection with the basal ganglia. So just because somebody's got some other kind of neurological condition doesn't mean that we can't treat their blepharospasm, even if it's part of that systemic disease. So eyelid myokymia just refers to this intermittent localized twitching of one eye that we were talking about before, but it's in the differential when you're thinking about blepharospasm. Obviously, it can occur secondary to anything that can cause ocular irritation. Tardive dyskinesia is the term for medication-induced blepharospasm, like the patient I was talking about. And then it can be a feature of much more significant disease. Huntington's starts as a dystonic, we get this chorea with it, so you get these dystonic movements. But again, you're not going to think that this is blepharospasm because this is going to be outside of just the eyes. Blepharospasm only affects the eyes. You can get facial tics, hemifacial spasm, which we're going to talk about. Focal seizures can sometimes present in this kind of way. It can be the start of some kind of nasty infection, and you can get these synkinetic movements with aberrant regeneration. Myasthenia gravis, they put on this differential just because it can be a cause of an intermittent and variable ptosis, but really they're quite different presentations, and don't think anyone would really get them confused from each other. So what do you do about them? You spend a lot of time talking to them and telling them that you can't fix them, and they don't like that. You've got to treat their tear dysfunction. So they are all sensitive to light, they are all dry. So whatever lubricants you can get them to use, the thicker the better. I like plugs, and then treating their blepharitis and getting them to understand about the need for the aqueous and the lipid part of the tear film and helping their symptoms that way. Sunglasses are great. Reducing stress. There's whatever ways they can. There's a little bit of evidence, and I'll talk about it at the end, of things like acupuncture, hypnotherapy, and what they can do to help. And certainly I'm quite in favour of anything that these patients can do that can make a difference in their lives. So they seem to be a little reluctant to sort of discuss these things with you. I think they think that all doctors are going to say that all that stuff is bad. So I quite like the idea that these are complementary therapies. I don't like the term alternative. I like people to think that all of these things are necessary and work together rather than that we do one as against the other. There are anticholinergic drugs that you can use. They have really long, unpronounceable names, not surnames. And while they're effective in a lot of people, I've basically not had any patients who can really tolerate them long term. And the problem with this condition is it's a chronic disease. They've got it forever. They all get sleepy. They all get neurological side effects from the drugs. They tend to be more miserable even than the blepharospasm. Muscle relaxants like lorazepam are really effective. So 67% of people who get lorazepam for blepharospasm feel better. They're highly addictive, and the problem is that they get tolerance. So they start on a really tiny dose of lorazepam and they feel good, and 6 months later they're doubling that dose to feel, to get the same effect. So long term, We all want to try and avoid these addictive medications. And they're just the odd number of patients who can respond to something else like baclofen or lithium. But again, the side effects really limit the effectiveness, and they're not as effective as some of the other better drugs with the worst side effects. So really, that leaves us with botulinum neurotoxin. So botulinum neurotoxin, there's 7 different strains of it, but the type A is the one that basically has the most powerful effect on the neuromuscular junction and has the ability to influence muscle action. So what is it? It's a purified protein that comes from Clostridium botulinum, and it prevents release of the acetylcholine at the neuromuscular junction. So if you understand how it works, it helps a little bit to understand what it does, especially from a cosmetic point of view. So this is your nerve ending. In order for a muscle to twitch, these acetylcholine little chemicals need to be released from the nerve, and then they activate the muscle. So if you have botulinum toxin, it comes around and it binds with the receptor and it prevents the release of the acetylcholine into the neuromuscular junction. So because the neurotransmitter isn't released, the muscle doesn't twitch. Unfortunately, there are things circulating around in our system that gobble up the Botox, and so after a very short period of time, the Botox is gone and it's the neurotransmitter, the receptor becomes available for the neurotransmitter again, so the effects of it wear off over time. So it's been used for a long, long time, Botox. The reason that it's sort of quite widely used in ophthalmology is it started in ophthalmology, so that's why lots of oculoplastic surgeons and other ophthalmologists use it in all sorts of ways. And it was initially used for strabismus and very quickly afterwards blepharospasm. It's quite interesting reading the stories of the first doctor that used it. I mean, you would think of all the conditions that you might try using some kind of neurotoxin, that injecting it to the extraocular muscles of the eye might not be your first choice of places to try it. But that's what he did. So basically just had patients with strabismus in his clinic, and he said, oh, I've got this idea of what I might do, and he started injecting. No ethics approval or randomized controlled trials. It was just like, hey, nothing else works, let's stick this needle in your eye. So once they realized that it worked for strabismus and blepharospasm, it got approved reasonably quickly, 1989, by the FDA in the States, and once it's approved by the FDA, can kind of go everywhere. And it very, very quickly expanded to include cosmetic indications. And now the list of things that you can use Botox for is absolutely enormous. It was quite interesting because the patients, of course, were getting treatment for their blepharospasm, and then everyone was noticing that they were looking a bit younger and prettier. So they very quickly leapt onto that. It's a huge industry. So sales of just Botox, which is the most commonly used product, $4.4 billion worldwide in the last, reported. I mean, who knows if that's actually true. Probably even more than that. So it's a massive industry. And the 2 types that we use most commonly are Botox, which is an Allergan product, and Dysport, which is also a type A. So it's the same, blocks the same part of the neurotransmitter. There's also a type B, because one of the problems with it is that you get resistance that forms, so people start to develop antibodies to the Botox, and then it's not as effective. But the type B is not as effective, hard to get hold of. I don't even know if we can get it in New Zealand now. But it's wonderful stuff for benign essential blepharospasm. So 90% of patients get symptomatic improvement, but it's not a cure. You have to see them every 3 months or sometimes every 2 months to get them the effect that you need. And they do develop tolerance. So you do tend to find that you need to give an increased frequency of injection and an increased dose over time. These are not the greatest photos, they're just taken from a video, but this is a patient who basically presented, and this is what she looked like. She could not open her eyes. This is the pattern of Botox that you use, and this is her just 10 days later. So it's quite dramatic, and she's had 5 injections around each eye to be able to have that improvement in effect. So this is what you do if you're going to inject Botox for benign essential blepharospasm. So you've got to get it in the orbicularis, and the idea is that you're giving quite concentrated doses, and you're trying to give it over a reasonably diffuse area. There's a photo actually here that shows the muscles that you're trying to use and basically the orbicularis is the main one. So your orbicularis wraps around the eye, controls the size of the palpebral aperture, but it's a really big, large muscle. So you have to give quite a lot of Botox into it to be able to be effective at stopping its action. There's also the procerus and the supercilious, which are these other two muscles here that are involved in the eyebrow coming down. And if you treat that muscle, you can get a bit more effect more safely. So what do you think the problem of going injecting all this Botox into the orbicularis might be? Should we just like stick heaps and heaps of it all around the orbicularis? Can't blink, yep. So you might find that they can't close their eye, and so you're going to make their dry eye a lot worse, yep. What else might you do? Is it, yep. So like overflow, like tearing, do you mean? Or, yes, exactly. So what other muscle is right in here that's also quite important for opening and closing your eye? The levator. So the levator muscle basically runs right smack bang underneath the orbicularis, and Botox doesn't just sit right where you inject it. Just like anything else that you inject, it diffuses out a little bit. And so the problem is that in order to paralyze the orbicularis enough to control their symptoms, you would invariably get the Botox into the levator muscle, and then you've given them apraxia of eyelid opening, but it's all induced by you, as in you inject it in there, the levator doesn't work, and they walk around like this. And believe me, they're not very happy with you when that happens. So it's really you have to be really careful to start off small and try and inject it into the orbicularis in tiny doses. So that's why the pattern of injection is like this. If you stay down quite close to the eyelid, which sort of seems like it would be a scary place to be putting the Botox in, you're actually a bit further away from the levator, which comes in and attaches to the top of the tarsal plate. So you have a little bit more chance of getting the orbicularis, stopping the spasming and the closing, but not affecting the ability of the levator to work to keep the eye open. So this is why these injections are in these locations. So this is getting the eyebrow to help to stop, and a little bit of the orbicularis. This is the orbicularis away from the levator muscle, and this is the orbicularis out in the sides, where again, further away from the levator, more chance of helping to reduce the blink, but not giving the problems. So yeah, the doses that you can use vary, but that's the kind of pattern of injection that you normally do. I usually start by not giving them anything in the top of the eyelid. I find, especially for their first few injections, they're quite sensitive to the Botox, and it can work really, really well by just staying out in the lateral canthus, and then I don't have to worry that I'm going to put them off totally by giving them mitosis, and then they come back and say, I'm never having that ever again. That was worse than the spasming. So Botox doesn't work instantly, so some people will walk out and say, oh, it's better the second I got it, but for most people there's a latent period, and it takes about 2 to 3 days before you see the effect. The maximum effect at 7 to 10 days, and it lasts about 12 weeks. There is quite a big range, probably because of where you're injecting it and the doses, and maybe the activity of the Botox as well. You can repeat it quite safely indefinitely. So there's no sort of build up in your system or problems with giving a neurotoxin repeatedly. And 98% of patients report getting at least some kind of effect from their botulinum toxin injections. So it's pretty cool response. 10 to 15% of patients needed higher than average doses, and this just increases with the amount of time that you're giving the patients the injections with this tolerance that develops. Depending on where you're giving it and the dose, most people get a little bit of a slight headache when you give the Botox. That increases when you give it cosmetically. There's a big risk of bruising, so 20% of patients get some kind of bruise. Definitely cause a lot of periorbital hematomas. I've got one patient who now comes in with her ice every time she comes to see me, and do I need my ice? And like we said before, the problem with injecting into the orbicularis is that you're going to reduce the blink rate, you're going to decrease the secretion of the tears. There's a very small risk of actually giving them exposure because they're not closing their eye completely at all. Because we're giving it down in the lower lid as well, you can get an ectropion. You can also cause an entropion if you manage to get it in the wrong place, or the orbicularis is sort of activated and flips the lid in. The rates of ptosis are quite high, but the rates of diplopia are very low, fortunately. And all of these things go away as the Botox wears off. So even if you give them a ptosis, within 12 weeks it's completely gone and back to normal. And the effect of the ptosis seems to be less than the benefit that they get from the loss of the spasm, from the reduction in the spasming. One of the problems with Botox, particularly when it first came out, was about its life. So basically the Botox comes in a little vial and you mix it, you reconstitute it with normal saline. And the problem is the activity of the Botox, once it's been mixed up, declines really rapidly. So for many, many years, it was said that you had to use the Botox just within a couple of hours of mixing it up. And you get 100 units of Botox in one vial, and really for most of these patients you need about 12 or 15 units. So you either want to have a whole clinic full of Botox patients that you're injecting, or you're throwing out a lot of Botox. It's $585 plus GST, last time I looked, per vial, so it's pretty expensive if you're giving 12 units and chucking the rest away. But fortunately, they've done some studies now by injecting it into the foot, which sounds a lot more sensible than testing it by injecting it into the strabismus, the extraocular muscles. And they found that fortunately, the effect of it, if it's stored in the fridge and kept cold, even after it's been reconstituted, that lasts for about 4 weeks without you getting any reduction in potency. So that's been really useful as far as being able to keep Botox and keep using it. For some patients, the Botox doesn't work and you have to do something else. So there are surgical options. Of course there are, like operating, but they're pretty gruesome. So you can denervate the facial nerve. If you denervate the facial nerve, you get lots of other problems. For a start, you're going to set those patients up and get neurotrophic disease or something like that. Yeah, it's just not a good thing to do. So really it's been abandoned. And so what you can really do, the only other option you can really do now is actually strip out the orbicularis, which is a pretty gruesome operation. I haven't got any photos, don't worry, you need to look away. But you basically make a blepharoplasty incision and then go all the way up to the eyebrow, all the way down to the cheekbone and strip out all the orbicularis muscle. It's really, really, really great for about 12 months. And then the patients get all their symptoms back again. So it's really not something that we commonly do, but one of the big benefits of it is that if you do a blepharoplasty and get rid of the orbicularis, you decrease the load of the muscle and the Botox can be a bit more effective again. Because the problem when you get some of these patients who've been injecting for years is the dose is really high and the chances of you getting into the levator and causing a ptosis goes up. So if you can take out the orbicularis, give them a bit less Botox and it works better, then you've got less chance of giving them side effects. So acupuncture, there's been 2 really good trials of acupuncture and some single case studies and observational trials, and it really has been, it's really good. It makes a big difference to the length of effect of the treatment. For some patients they can go 6 months instead of 3, and it seems to make the Botox that you're giving them work better as well, but it doesn't seem to be a substitute for it, so definitely worth it. Biofeedback, no options really for this in Christchurch as far as proper electrical biofeedback goes, but basically you can attach electrodes and then train your body to kind of modify the response by doing some biofeedback, and this is about trying to get the eyes to relax and other parts to activate. Hypnosis, again, there's some studies that have been done that show that hypnosis can be beneficial. Basically, the theory is that you're putting a patient in an altered state of consciousness and then telling them that they don't have blepharospasm, and then when they wake up, they stop twitching. I'm perhaps not so convinced of the hypnosis as I am of the acupuncture. There are lots of other sort of complementary therapists out there that are offering patients support for this condition. So there's craniosacral therapists, chiropractors, that sort of thing. There's not a lot of evidence about these, but you certainly hear from patients that it gives them a great deal of benefit. And this is such a nasty condition that we don't have any cure for, that I'm kind of a fan of anything that might help a little bit. So if patients want to go off and try this and they find some benefit, then that sounds good. And then it's all those things that we're all supposed to do. Mindfulness, getting plenty of sleep, exercising, breathing, and just being conscious of that, and watching our diet, particularly the caffeine and the alcohol, trying to get rid of stress, And there are some herbal remedies that have been purported to help as well. Blepharospasm can be, and again, a bit slack in getting some photos from my own patients prior to this talk, but you can get these extended blepharospasms. So while I've said that it only ever affects the eyelids, it can affect all of the facial muscles. So there's a syndrome called Mige syndrome, or ocular cervical dystonia. And it affects the muscles, and it's a severe form of blepharospasm, but it also starts to affect the lower face. And my particularly memorable patient who's got this condition came in one day and she said to me, "It's great, I can drive now and my eyes are open and I'm so much better." She said, "But I really have trouble cooking." And I said, "Oh, why is cooking so much more difficult than driving and working in the computer?" And she said, "Well, when I'm cooking, I seem to need both hands. But when I'm driving, I can manage to hold the wheel with one." And I said, "Well, what are you doing with your other hand?" And she said, "I'm holding my head up." So she's got this video of what she's like, and because of the dystonia in her neck, she's like this all the time. So when she's doing anything, she's having to hold her head up. But when she's trying to cut up, something or cook something, she can't do it. So she's got a video of her cooking, like trying to do this. So now we've got her onto the neurosurgeons, and she's having some Botox in her neck, which is helping a little bit. I feel a bit sorry for the neurosurgeons though, because if we kind of get our dose a bit wrong, they get a droopy eye. It's a bit annoying, but it sort of comes right. If they get their dose a bit wrong, patients can't breathe, can't swallow. It's not sort of compatible with life. So they have to do their Botox injections. It's a lot more sophisticated. They do EMG, so they have little electrodes attached to the muscles, do some twitch testing first, and actually check that the muscles that they're injecting the Botox into are the latissimus dorsi and are the muscles that are actually affected, and that they're staying well away from anything that will help people breathe and swallow. So this guy used to sell, he was a farmer, and then he stopped farming, and he had big paddocks full of Christmas lilies. But this guy's got hemifacial spasm. So I don't know if you can notice the left side of his face. On the left side of his face, his eyelids flickering and twitching. Anyway, this is hemifacial spasm. So this is always unilateral, but it affects the whole side of the face. So it's not just the eye now. They almost always come in and they complain about feelings of pulling and sensations down in their cheek and their mouth, always unilateral. It usually starts around the eye, so they often present, again, they can have this little flickering to start with, and then it progresses on. They don't have any sensory change, so the feeling and everything on the face is really normal. It's less common than blepharospasm, so we've got about 30 per 100,000 for blepharospasm, only 11 per 100,000 for this. This also interferes with things like reading, and tasks that require concentration tends to be able to be suppressed again. This goes on while they're asleep, whereas blepharospasm tends to stop. Still more common in females than males, and similar sort of age. It progresses, and as well as the twitching, they get weakness of their face, so they often come in and they've got a little bit of a facial droop. So you might be sort of looking at them thinking, have you got a seventh nerve palsy or something? But this is a really important condition, not because we want it picked up and treated, but this can actually be fixed, and it's also associated with nasty things inside the brain. So when you've got this twitching on one side of the face only, when it's around the eye, that's when you need to be a little bit more concerned. And while it's still not a common thing to have a nasty tumour in there, they certainly all need imaging. So the most common cause of it is actually compression of the facial nerve by an artery inside the brain, and it's thought that the artery, as it pulses, stimulates that nerve that it's sitting on and causes that nerve to trigger, and that's why you get the flickering and the twitching. But you can also commonly see tumours of the cerebropontine angle or the brainstem. Most of them are benign, meningiomas, parotid tumours or acoustic neuromas, but occasionally nasty. But the incidence of tumours in this population is about 10%. So we've got less than 1% for the blepharospasm and 10% for these patients. And this is actually really idiopathic. So most of the time we can find a cause for why patients have got hemifacial spasm. Probably not so used to looking at MRI scans and knowing what you're looking at, but these are the eyes. Obviously, so there's the eyes, the optic nerve, the nose, the brain, and this one shows it up best, but this is a big acoustic neuroma sitting in the cerebellopontine angle. So this is a big tumour. And this is actually that man scan. But that's much less common than this compressive spasm. Most commonly, this happens just as the facial nerve exits the brainstem, so around the back, just behind your ear, which is good because it means that there's access to that area. And the thought is that this compression causes this loss of this myelin sheath, and when there's no myelin on the nerve, then the signals can travel down more quickly, and you can get these ectopic impulses going down the nerve. So if you can decompress the artery, the myelin recovers, and you get rid of these symptoms. So you can have a patient that's got this horrible twitching and spasming, can go and find the area where the artery is causing the compression in this area here. Oh, that's not very accurate on there. You can go in and you can find, the neurosurgeons can, not me. And this is the nerve and this is the artery, and you can see this is the area where the artery is rubbing on it. And they literally lift the artery up and put this little pad of Teflon underneath the artery against the nerve, and the patients are fixed. It's amazing. Surprisingly, maybe, or most patients don't end up having this done. So most patients you can still treat with Botox and they're quite happy. The reason being that although there's an 80% response to the surgical treatment, there's a 1 to 8% chance of permanent deafness, an 8% chance of permanent facial weakness, and a 1% chance of having a stroke where you get your whole side of your body affected. So a number of patients decide that they're twitching and flickering and slight weakness, that they'll leave the brain surgery, thank you very much, and keep coming to see me. So we still do it if we can't identify the site of the compression, if patients don't want surgery, or for milder disease. And again, it's still effective in 90% of patients to reduce their symptoms. You have to give them more and you have to treat further down the face. So this is the comparison of the hemifacial spasm on this side and the blepharospasm treatment on the other side. So really, what's important, the blepharospasm is always bilateral. It's mostly, or it's essentially idiopathic. We don't need to investigate them, and they all need Botox. Don't forget their dry eyes and treating that. Hemifacial spasm is unilateral, but we need to investigate them. So if they've got twitching on one side, we need to know, and we need to see them and do some imaging. Mostly it's caused by compression of the facial nerve, and we can cure it, although often we don't, and we treat them with Botox. So before I do a whistle stop through facial rejuvenation, and what we can do for these sorts of patients, have you got any questions about that first part?
So you have more sort of younger patients come through. Is it particularly myoclonus or is it sort of blepharospasm?
Oh, no, loads with actual blepharospasm that we're having to treat with quite high doses of Botox. I don't know. I'm not sure. But I mean, I've had anything from teenage, up and through their 20s and 30s. And they seem to be really quite severely affected as well. So I don't know if it's, probably blame it on earthquakes and pandemics and these things that have been happening, and stress, whether that's just bringing it out earlier. And it'll be interesting to see. I don't know whether they're going to now become patients who need treatment instead of for 40 years, they're going to become patients who need treatment for 60 years, every 3 months. Oh, they're mostly, no, mostly. Yeah. But no, I don't know the incidence. Okay, so whenever anyone hears Botox, they always think about the cosmetic indications for Botox and what it can do for you. This is an example of a computer image of the aging face. Unfortunately, it happens to all of us. So as you all know, our skin loses its elasticity. Because of gravity, everything sinks. And because of repeated movements, we develop lines in the skin over the top of the muscles. So basically, it's the muscles moving underneath that cause the lines. So commonly referred to as the non-surgical facelift. What can you do? You can use Botox, but as we know, because we now understand about the way that Botox works, it stops the muscle from twitching because it's released from the nerve. So it doesn't plump up the muscle or do anything to the muscle. It just stops the muscle working. So Botox stops lines by stopping muscle action. So if you've already developed lines and wrinkles, Botox doesn't really fix all of that. Botox just stops the muscle from working. And so that's why it softens lines, and people would now suggest that really because of that you should use Botox as a preventative therapy in your 20s. I'm not suggesting that, I'm just saying that that's the sort of argument that people now come up with, because if you can stop the muscles from working, you won't develop the lines in the first place. But if you've got these deep lines, then really you have to use fillers, and that's all you can do to restore lost volume. So because of the muscles in our face, this is a diagram of all the muscles of facial expression. You can see that that quite nicely mimics what happens to the face as we age, just through all these muscles working. So really it's just a sign of hard work and a life well lived. But lots of people don't want to show their age on their faces. So before we go on to sort of the cosmetic things, these are just some of a very, very, very long list of things that Botox is used for. So neck spasm and torticollis, cerebral palsy, it's really commonly used in cerebral palsy to try and prevent the contractions that occur in kids, and huge doses, like 100 times the dose that we're using around the eye. Really effective for migraine, and also excessive sweating, palms quite commonly, but also axillas, really, really good for that, which can be a really embarrassing problem for people. It's used in the bladder to try and stop bladder spasm and help with people who get urinary frequency. There's a few people using it for painful neuropathies to try and actually prevent the nerve from triggering and to stop the neuropathy. And it's used for vocal cord dysfunction as well. So some pretty cool things that it can actually help with that are impossible to treat in any other way. It's been used to treat millions and millions of people multiple times. Last year, the American Society of Plastic Surgeons, there were 7.3 million Botox procedures done in the US by that group of people. We use, as I say, these tiny doses cosmetically compared to what we'd use in a child with cerebral palsy. It has no permanent side effects, it has no systemic side effects, so it can't do anything to the rest of your body, and any of the adverse effects that we get from it are transient. So it's a pretty safe thing. Unfortunately, it's not going to help someone who's got to this stage. This is sort of the cosmetic promotional material that they give you, why they insist on using young, beautiful, non-wrinkled people as their models. Anyway, these are all the areas that you can use Botox or do enhancement to try and continue to look young and plump. Obviously, I don't do all of that. But what happens if you do cosmetic Botox? You come in, have a consultation, take photos, you clean the area, and then you give tiny little injections of Botox. That's like having an insect bite. It stings for a few seconds, tiny red raised area, and the whole thing takes about 10 minutes. You'd leave and nobody knew you'd had anything done. Depending on where you're giving it, you're using pretty small doses. So to get an eyebrow to lift, if you want that Judith Collins look where you go down like this and then your eyebrows go up in the air. I'm not sure why anybody wants to look like that, but some people apparently do. You only need tiny little doses. You can combine that with preventing the glabella from frowning, which I would highly recommend as making you feel less angry as well. But you can see that the doses vary depending on how big the muscle is and how much you need to use to paralyze it. There's two sorts, so some people will advertise Dysport and some will advertise Botox. Really they're exactly the same thing, both botulinum toxin A made by two different companies. They do have different potency, so they are diluted a different amount, so you have to inject more of the Dysport and less of the Botox. Some people believe that if you move from one to the other in patients who have some antibody resistance, that you can get more effect again. So I think there probably is something in that, even though they're the same type A botulinum toxin. But really it comes down to the drug reps and how effectively they can market and sell their product and what pricing they're going to give to people. So I don't think there's any difference between them other than that. So the kind of normal places that ophthalmologists might give Botox, and I don't really do any cosmetic Botox apart from friends and family and some of my surgical patients, so I don't have a large cosmetic Botox practice at all, but this is the sort of thing that you can do. So this is a patient who's got quite significant crow's feet. This is 6 injections that she's had. out to the side and around, quite small doses, only about 12 units in total. This is what she looks like when the Botox is working to its maximum effect. And this is as it's starting to wear off. So this is 3 months down the track when the lines are starting to come back again. So it doesn't make anything worse. Once the Botox wears off, you just go back to what you would have looked like before. The effect is quite variable between people, like we said before, same as when you're treating a pathological condition. About 2 to 3 days before you start to see an effect, 7 to 10 days to get to the maximum effect, and then really 3 months until it starts to wear off and your movement appears again. But wears off gradually, and some people it will last longer with additional treatments because the Botox sort of builds up in there a little bit, and others, they get this resistance and you need to give it more frequently to get the same effect. Probably the most commonly injected site is the glabella region, so these nasty frown lines, and this is the sort of effect that you can get after you've given the Botox in as it's starting to wear off again. So this is quite a good example of you relax the muscle, so the muscle can't activate anymore, but you still have the line, and you can't get rid of it completely. This is an area that people then, when they've got that line, start to think, oh, maybe I'll have something like some filler. And this glabella region is really, really, really high risk for injecting fillers. And the patients, particularly, it's been quite a large series of them in Korea. So Korea is probably the country in the world that has the most cosmetic procedures done. And there's a connection between your arteries around this area, and the problem with injecting filler in this area is you can get antegrade and retrograde flow, so you can inject the filler into your artery that goes straight to your central retinal artery and gives you a central retinal artery occlusion. So there's been quite a number of reports of blindness from injecting filler into the glabella region, so just heads up, probably not an area that you want to go and have your filler injected, in my opinion. Really, the side effects are minimal. Most people have none, or if they have any, they're transient. You do sometimes get reports of a slight headache. Some people do say they feel slightly unwell afterwards for a day or two. Bruising is something that you can get, and it's quite common. And some people get a little bit of funny twitching afterwards. Ptosis and diplopia are rare, but not impossible around this area, especially when you do along the top of the eyebrow. So again, just the effects that you can get from Botox, again, a commonly done area in the forehead with the Botox working, and then afterwards. This is exacerbated in these photos because this is the patient actually lifting their eyebrows up and making the lines appear. So how much does it cost? It depends on the dose and the number of sites. Basically, it's charged per unit of Botox, so the more Botox you need, the more it costs. So most of the time, looking at about $300 for 20 units, which would give you enough to do your glabella region, but if you wanted to do your frown, your glabella, and your crow's feet, somewhere around $500 to $600. About the same as having hair and makeup done, some people would say. Yeah, exactly. I'm not, this is not a sales pitch. I'm not, as I say, I don't actually do it. So yeah, it's more to inform you what is available, and you know, patients might ask, and you might be interested yourselves. So what about fillers? This is really, really brief. We're just about at the end. Hyaluronic acid is the most commonly used, but there's all different sorts of hyaluronic acid depending on the number of side chains and the density and viscosity of it. So there's heaps of different products now. So you can use really heavy, thick ones to inject in the cheek and the top of the tear trough, and you can use nice, fine little ones to inject in the lips. But basically, hyaluronic acid is something that's found in our body anyway, so it's natural to inject hyaluronic acid fillers. As we age, our hyaluronic acid reduces and we lose volume in most of our tissues, not just because of loss of hyaluronic acid, loss of fat, gravity, everything's sinking down. So this is not a natural substance. It's manufactured in a laboratory to simulate the naturally occurring hyaluronic acid. And it has a temporary effect when it's injected under the skin of plumping up the skin and giving more volume. So the common places that it's done are under the eyes, so along the top of the cheekbone to hide the tear trough, in the folds between your lips and your nose, so your nasal jugal folds down here. quite a good place to get them. This one's getting quite bad. And to plump up the lips, which seems to be quite a trendy thing at the moment and seems to be quite the rage, to plump up your lips so much that instead of having a curve going this way, we seem to be wanting to turn everybody into those things that look like clowns at the fairgrounds. You know, they have those lips like that and they get that. Anyway, just be careful. Little bit's okay. It's an in-office treatment. It has immediate effect, although you do get a little bit of swelling and bruising, so it's not like Botox where you can give it and you go out and nobody would know. Definitely can be a little bit more obvious that you've had something done. And it gradually resorbs, and the amount of time that it lasts for is really actually quite variable, and it depends where you're injecting it. So if you're injecting it in the tear trough where there's hardly any facial movement, it actually lasts quite a long time. So you might get a couple of years of benefit from filler in the tear trough, whereas if you put it in the lips and you talk a lot, it goes quite quickly because it's all broken down. It's reversible, so you can put hyaluronidase into the hyaluronic acid and dissolve it all away. So that's quite reassuring. If you put it in and you don't like the effect of it, you can dissolve it all away. And this is the sort of natural look that you can get with some hyaluronic acid. This is not my patient, but I think this looks pretty good actually. So I think it is a worthwhile and useful thing for some patients when it's given sensibly. So Botox is quick, safe, pretty much pain-free, and gives you a natural look for about the same cost as a regular haircut. Fillers might be an option to restore volume in specific cases, and for some of them, none of that will work and you really have to do surgery. So blepharoplasty, upper and lower lid blepharoplasty for some patients is going to be the only option. And it doesn't always go well. So there's heaps and heaps of photos on the internet of bad Botox. This lady is an influencer, and this is her beforehand and this is her afterwards. So yeah, she had Botox, which gave her ptosis on the right side, and then this retraction that she's got on the other side because she's trying to lift her eyelid up so much that she's getting pseudo retraction of her other lid. And she's put a whole series of photographs over the 6 weeks that it took before everything all came back to normal again. So you do just have to beware. If I'm doing that to my patients that have blepharospasm, they're pretty understanding. But if you do that to a cosmetic patient, they're really not very happy. I think that's why Madonna went through a period of wearing an eye patch. I don't know if you just not so long. It's just my personal opinion that she tried to make eye patches trendy and use it as a design thing. I suspect that she'd had some bad Botox and had a droopy eyelid and wanted to cover it up. So the whistle stop tour through twitching, and then what other things can we do with Botox? So if anyone's got any questions, happy to take them. Oh, it's like, who's talking? Hello, Lucy. Not so much, because there's not such a connection. There's not such an anastomosis there. So you've got your nasal dorsal artery that comes down in this region that goes basically straight back and joins into your internal carotid. So this area is definitely the most risky. Go for it. I mean, yeah. There will be, I'm sure, cases reported of filler being injected in all sorts of places that have had complications, but the most common place for a problem is in this area.
Okay. With regard to myocardium, you talked about mainly the lower lid.
Yep.
If it's upper lid and it's persistent and definitely no stress caffeine related, is there a time frame when you suggest to?
I think 6 months is completely reasonable. Like if it's persisted for 6 months and people are distressed by it, then I think it's reasonable at that point to try treating them. And I've certainly seen loads of patients where they've been really bothered by it. You give them 1 dose of Botox, and either you give them a ptosis, I don't know, they don't come back anyway. So either it didn't work, they didn't like it, or actually it's, I presume, fixed them and it's gone away. Absolutely not. No underlying problem. So as long as it's unilateral, upper or lower lid, it's more common in the lower lid, but certainly can happen in the upper lid. But definitely you don't need to worry about it. You don't need to investigate it. It's not associated with intracranial pathology. So the odd patient will progress to a hemifacial spasm. So if it's clearly starting in the top lid and then after 6 months they've also got some twitching, somewhere else, then yes, you should be concerned. But that continued, isolated, intermittent. That's the other thing with it, is it tends to be quite intermittent. They'll have periods of the day where it's annoying, periods of the day where it's gone away. They might have some days where it's there and some days where it's not. Whereas with the pathological forms of it, it's pervasive. It's always there, every day, most of the day. Yeah.
Have they got a generic version of Botox?
No. Well, the Dysport's is sort of close as you get to that. The Dysport's cheaper, but you need more of it. And you have to inject larger volumes. So I don't really like it around the eye because I want to give a low-ish concentration, so I'm reducing my chances of complications, but also a small volume. So I don't want to have it spreading everywhere if I can avoid it. When Anthony injects it into muscles, which he does quite commonly, he uses a really, really concentrated tiny volume. So he's using like 0.1 of a mil and getting 10 units straight into that muscle. Whereas I'm using 0.1 of a mil and getting 2 units. So quite a different, because I want my widespread effect when I'm injecting it. And he wants it really accurate. He does it with, not all the time anymore, but certainly when he started, he did it all with EMG, like the neurosurgeons do. Identify the muscle, make sure you've got the right place and inject it. Now, quite commonly with the medial rectus, he's just injecting it. All right.